Welcome to the third webinar, the 2021 Virtual Chordoma Community Conference Series. Anna Lozinski, Director of Patient Services at the Chordoma Foundation. The first webinars of this virtual conference series focused on pain management and cancer-related fatigue. You can find recordings of those on our website, chordoma.org, the webinar library, and you can also go to the community conference page of the website to find the dates and topics for the remaining two webinars of this year. As many of you know, the Ask the Experts panel is a traditional part of our annual in-person conferences and one of the most well-attended and appreciated sessions. We're very grateful to this for being here with us today, so we can bring you this session virtually. There are no presentations for this webinar, just the next 85 minutes for Q&A, and so we will do our best to get to all of your questions during that time. So without further ado, I will introduce our moderator for today. Dr. Ed Less is a Clival chordoma survivor. He has been part of the Chordoma Foundation in some way or another for over 10 years. He is a member of our board of directors, is of our patient services committee, and also sits on our community advisory board. Ed has moderated many of these Ask the Expert sessions over the years, and thank him for being here with us again today. And with that, Ed, I will turn it over to you.
Thank you, Shannon. You can hear me okay?
Can hear you just fine, yep. And to the rest of the doctors, you can turn your videos on now so everyone can see you. All right, thank you.
Awesome. Thank you for having me again to do this Ask the Experts panel. It's always much appreciated by the Chordoma community. So thank you once again, Shannon, for helping to orchestrate this session that our community of Chordoma survivors and family members always find very, very useful. I'm a Chordoma survivor myself. I've been living with Chordoma residual for a bit more than 14 years. I live in Calgary, Alberta in Canada. I'm a physician there at the Children's Hospital. And I've been part of the Chordoma Foundation, currently a board member there, and pleased to be part of helping to run this panel again today. So without further ado, I'm pleased to welcome our four esteemed panelists. I won't use the entire 90 minutes to list all of their credentials because it would take me probably a couple of hours per person if I was to do that. So just briefly, I'd like to welcome Dr. Ziya Gokaslan. Dr. Gokaslan is Chief of Neurosurgery at Rhode Island Hospital and Chair of Neurosurgery at Brown University Medical School. And we also have Dr. Vinai Gondi, who's a radiation oncologist at Northwestern University, where he's also the Director of Research and Education and Director of the Brain Tumor Center. Also with us today, we have Dr. Mrinal Gounder, who is a medical oncologist at Memorial Sloan Kettering Cancer Center and lead clinical researcher there. And last and certainly not least, Dr. Erin McKean, who is an ear, nose, and throat surgeon and director of the cranial-based surgery program at the University of Michigan Medical School. So thank you all for giving up some of your very valuable time to help us with this session today. And so just a couple of remarks with regard to the questions that we'll be going through. I have a list of questions that were submitted by many of you in the community before the session today. Rest assured, we will try to get through as many of those as we can. If you don't hear your question specifically articulated, that doesn't mean that it's not included. Some of the questions are overlap with each other, and so I've taken the liberty in some cases of rolling those questions into one query rather than covering the same ground multiple times. And as Shannon mentioned at the beginning, if there are other questions that come to mind that you would like to have addressed, put them into the question and answer box, and if possible, and if time permits, we will cover as many of those as we can as well. And then just to reiterate one more time that we are not offering medical advice, we're offering expert insight into what we know about chordoma in 2021, which rest assured is far more than we knew about chordoma before the Chordoma Foundation was launched 14 years ago, 13 years ago, I think, Shannon, you stand corrected. In any case, without further ado, I will I'll start by directing the first question to Dr. Gondi. Oh, and I should say also, a lot of these questions have, managing chordoma, as all of you know, requires a concerted team approach. And so many of these questions really are fair game for all of our panelists. What I will do is start with one panelist, and if appropriate, then other panel members can weigh in as they see fit. So to Dr. Gondi, I have a patient with sacral chordoma who had a partial resection and then another surgery performed to remove more of the tumor. It has a question about follow-up scans in the aftermath of surgery. How many months between MRI and for how long? And is a CT scan needed regularly, a chest CT scan? And is at any point a full body scan indicated at any point?
Well, first of all, many thanks to the Chordoma Foundation for the very kind invitation to come back and speak during this webinar. Dr. Les, always a pleasure. Good to see you again. Hope you are well. This is a really good question in terms of surveillance of patients who've been managed for their chordomas. A couple of important principles. Number one, surveillance for chordomas, as many of you understand, is a lifelong process. So for the rest of their lives, it's really important to continue to image and follow them, given the potential that chordoma recurrences can happen years to decades down the road. Number two, MRIs relative to the local site prove more advantageous than CT imaging. When we talk about a spinal chordoma, maybe not necessarily sacral chordoma per se, sometimes instrumentation can preclude that and make that a little bit more challenging. But certainly MRIs, given the fact that these lesions tend to be very sensitive from a T2 imaging to be quite T2 hyperintense, it becomes important to continue to follow them with MRIs of the sacrum in this case. And generally speaking, my approach is to do it every 6 months for the first few years and then stretch it out to annually thereafter. In terms of chest CT surveillance, it's interesting. I've been fortunate to be part of these webinars a couple times in the past, and find it interesting to hear from everybody's perspective in terms of how they manage the CT surveillance of the rest of the body. I believe there's a lot of different approaches. In my experience, patients have the propensity to develop metastatic dissemination from their chordomas. But in general, they tend to happen either when they first present or when if they develop a recurrence locally thereafter. So I don't necessarily routinely do CT imaging lifelong like I do MR imaging of their primary site. And that's just my personal experience and preference. But I am interested to hear what all the other distinguished speakers have to say on it.
If I may, I treat a lot of sacral chordomas, and I fully agree with Dr. Gondi's sort of the protocol that he articulated in terms of surveillance. A couple of points. I personally do MRI scans of the sacrum within the first year every 3 months. And the reason for that is occasionally you have a patient with the differentiated chordoma and you end up getting a fairly early recurrence, which necessitates additional treatment quite urgently. And hence, to be able to catch those rare instances, I tend to do my early on within the first year. The first set of scans I do every 3 months. Again, I fully agree with Dr. Gondi that the chest CT, typically I would reserve that when we see a local recurrence, which is typically monitored every 6 months, every year. And most of the time, the metastatic disease really occurs after the local recurrence. And hence, if the local site is completely clean, I don't necessarily periodically look at the chest.
I do get a chest x-ray once a year, or if there were nodules on a previous imaging, then I would follow a CT scan. But I know the consensus guidelines from a while ago, but I tend towards chest x-ray and following that if something shows up there.
Great, thank you very much. We'll move on to the next question. Pick on you again, Dr. McKean. have a question from a participant whose mother had surgery to remove a Clival chordoma and had a small residual left behind, which is pretty common, about less than a centimeter, but it's in an unfortunate spot abutting the basilar artery, so one of the key arteries to the brain. And her surgeon said it was too risky to remove it. And so the question relates to the DaVinci Robot procedure. Do you know of any procedures, including the DaVinci Robot, that could be used to reach the tumor in this area, and anyone who has performed the procedure? And just to the audience, the question about DaVinci Robot procedures come up a few times, and so I thought good to address that early on.
That's a great question. I'm glad that has come up. I would believe, without seeing the imaging, that the issue related to I have to trust a little bit what the surgeon saw at the initial being in there on the basilar artery is probably less to do with the ability to access it. So the DaVinci Robot, which is basically robotic arms, because I see in the chat, somebody's asked, well, what is that? It has robotic arms that can go in, and our hands have so much degree of freedom, but if you have a robot on a long handle and it's got the ability to twist 360 degrees over and over, it can do some things that we can't do with our bare hands in some places. Back to the question about, is there anything else? I believe what I'm hearing from your surgeon probably is, it has less to do with the ability to access the exact site and probably more to do with how sticky the tumor was, how stuck it was to that really important artery, and their fear of giving a devastating stroke or devastating complication that would just be terrible. And so it's a balance of doing what's safe and following along if that's safer, probably less access and more just about their concern for complications.
Dr. Les, can I add a few points from a radiotherapy perspective, if you don't mind? I actually think this is a really good question too, both from a surgical perspective, but also from a radiotherapy perspective. As Dr. McKean eloquently stated, it's a risk balance when it comes to surgery. So when I see a patient whose preoperative imaging suggests that it is touching the basilar, then I assume there are tumor cells on the basilar, whether it's been taken out or not, because it is very difficult to scrape a sticky tumor off the basilar, understandably. This is where I think, I do protons as sort of standard of care management for chordomas, and this is where I think there is a clear advantage for proton therapy, where we're able to use the sharp edge of our beam that we have with protons to leverage that dose fall off that we need between the ventral surface of the basilar, in some cases, the 180-degree aspect of the basilar and the brainstem surface. And so that becomes an important consideration. So it is not uncommon that I see patients who are referred to us with either residual or presumed residual along the basilar.
Thank you, Dr. Gondi. I think that's a key point, and that's a question that's come up often over the years, and relates to the whole gross total resection language that is used. And it's often not widely recognized in the community that gross total resection doesn't speak to microscopic tumor left behind, which you just eloquently described. I have a question. I'm going to take a question from the question and answer panel regarding genetic profiling and direct that to Dr. Gounder, if that's okay. The genetic profiling, please comment on genetic profiling, the best type of test to get and how it can be arranged and how it is used, if it is used to guide therapy at the time of diagnosis or at the time of recurrence, as the case might be.
Oh yeah, thank you. This is an important question that we've been working on for many years now. I think first thing I'd want to say is that, I think there is a lot of high quality data for surgery as well as radiation in the management of chordoma. But when it comes to medical therapies, when it comes to things like, the utility of genetic sequencing to help a patient, we are still very much in the early stages of understanding and learning. So there's a lot of uncertainties at this point, but overall, we still think that there is some value at this point to do genetic sequencing. So let me explain more. Genetic sequencing is a sort of a loose term. So whether you look at one gene that may be responsible for what may be driving a chordoma, or whether you're looking at 500 different genes at the same time, with the hope that maybe you can decode the underlying process that is leading to this cancer. It really depends on what kind of tests you use. There are hundreds of tests out there. Some tests are extraordinarily good. Others are not so good. So when people say, you know, should I do a genetic sequencing on my tumor? My short answer is it depends. It depends on a lot of different things. And let me explain when is the right context and timing to do a genetic sequencing, and when I tell my patients, you know, you should hold off on doing something like this. And the second question to that is, what kind of testing should one do? So to answer the first question as to when should you do genetic testing, if the diagnosis of chordoma is quite clear, the pathologist is an expert pathologist, has looked at it and said, this is a conventional chordoma, or maybe this is a de-differentiated or poorly differentiated chordoma, and they've done some basic tests, and they have a good confidence that this is the right diagnosis, there really is very little utility to do a genetic sequencing at that point. If the chordoma is localized, has been fully resected, and the margins are clear, or even if they are microscopically positive, or they've had radiation, and the next step plan is we're just going to monitor for the next couple of years, I do not get genetic sequencing on those patients. And why is that? It's because the technology of genetic sequencing is constantly evolving. Every 3 months, the tests are getting better, and the costs are also dropping. So I tell my patients, don't do anything right now. Wait to see. Maybe this will come back. Maybe you're cured. We don't know. If it comes back, at that point, we can certainly have a conversation about genetic sequencing and see, can we learn something from this in order to inform therapy? The people with whom I discuss about doing a genetic sequencing are those patients who have recurrent disease, those who are not operable or can't get more radiation, or those who have metastatic disease. I think in those cases, when they see me as a medical oncologist, they're really coming to me to say, well, are there any drugs for me? Are there any clinical trials that are worthwhile for me? So in those circumstances, I do think the genetic sequencing may help. I don't think we have very strong evidence to say that this is helpful in X% of patients. But we do occasionally pick up patients for whom we find an interesting mutation or a gene to which we can enroll them in a particular clinical trial or a particular drug. So I think this field is early. I think the next several years we'll have a better sense of who are the right patients to sequence and what are the types of testing to do. While I'm not advocating particularly for any one commercial entity over other, the one commercial, at Sloan Kettering, we have our own genetic testing. It's very comprehensive. We use this for all the patients who come here. But for those who are not able to see me, I happen to refer them to Foundation Medicine. They have a very nice panel. It's been validated for more than a decade now. But that's just my preference. I'm not saying that this is better than others or others are inferior.
Thank you, Dr. Gounder. Complex topic for sure. I think at the beginning of this sort of thing, many people had pinned perhaps outsized hopes on how it would revolutionize treatment, but clearly evolving rapidly as time goes on. I personally used Foundation One as well for my management of my tumor, and it did help me, but certainly not a panacea. Perhaps related to that question, if I could just cover it now since we have you on screen. There's a question regarding liquid biopsy and how it can help to select treatment and how it can guide diagnosis and that sort of thing.
Yeah, so I think liquid biopsy is clearly something that's very important. So for people on the forum who may not understand what that means, let me just briefly explain. So say you have the tumor tissue, it's been biopsied or surgically resected. You send a very small, tiny piece of this tumor to the company or the place that is doing this genetic testing to see, well, what kind of genetic mutations does my cancer harbor? But for some patients, that could be invasive. It may require the chordoma may be in a very tough location. It may not be possible or safe to biopsy. So how do you learn what is the genetic sequencing for that patient? So this is a problem that's not only relevant for chordomas, it's actually relevant for all cancers. There are, say, a lung cancer may be in a very tough location, or a brain tumor. So the alternative to that is, can we take a tube of blood and see if there are any cancer cells or small amounts of cancer DNA that may be circulating in the blood? Can we capture that DNA and use that as a surrogate of what's really happening in the tumor tissue itself? What I can tell you is that this is a very complex field. And the reason it's complex is that there are some tumors that shed DNA and other tumors that don't shed DNA. We don't have a very good sense, or at least I'm not aware of any publications recently that say how much do chordoma cells shed their DNA into the bloodstream. If my suspicion is that it's probably quite low. There are certain types of tumors that shed a lot. Chordomas don't. My sense is that they don't shed much. So the likelihood of being able to use liquid biopsies in chordomas, one, has not been fully studied, and two, we just don't know at this point. But it's certainly very helpful for many other cancers. There are some studies that the Chordoma Foundation is supporting, where things like circulating tumor DNA and liquid biopsies and things like that are incorporated into the studies to precisely answer these questions. But I think the next several years we'll have a better sense of how useful liquid biopsies are.
Awesome. Thank you, Dr. Gounder. Dr. Gondi, you had a comment to add, I think, regarding the molecular testing, and then I'll pitch another question to you once you've made those comments.
Sure. Thanks, Dr. Les. I want to add to what Dr. Gounder mentioned. There's one scenario I was thinking clinically in my modern management of chordomas when I do consider molecular testing, and I actually used the panel developed by the University of Pittsburgh team, where they've tried to risk stratify. I think we need some validation on their work, but given what they have, I think it's interesting enough. And when I have used it is when I get a phone call from a skull-based surgeon or a rad-onc from elsewhere in the country saying, look, I got this chordoma and patient, and I think they benefit from protons, but they can't make it to Chicago for whatever variety of circumstances, social, financial, what have you. And what should we do? And I typically suggest at that time, well, why don't we just send the tissue to Pittsburgh and allow them to molecularly stratify based on the data we have. Again, we need validation. And maybe that will allow us to inform, maybe we can observe this patient. Maybe we don't need to treat them with proton therapy, and we can just see how they do. The alternative is sometimes if there's residual, maybe just radiosurgically treat the residual and then watch carefully. So I have implemented that into my practice right now, in part because these scenarios are not too uncommon.
Thank you. I have a question related to radiation more generally. Obviously, now we have quite a bit of experience using proton or combined proton-photon radiation to try to halt the growth of chordoma. What's the current data with regard to the success generally with regard to stopping growth or limiting growth of chordoma with proton and photon radiation?
Yeah, so it's a really good question. So the goal of radiotherapy, importantly, is to stunt residual tumor, both macroscopic, like tumor we see on an MRI that's left behind that cannot be safely resected, and the microscopic stuff that we know is there, and stunt it and as durably and for as long as possible. And the goal of radiotherapy is to extend time for as long as possible in terms of control. What we understand about chordoma specifically is there is a dose response relationship, meaning the higher the radiotherapy dose we can treat, the longer we can control chordoma. Obviously, some of that has to relate to something that Dr. Gokaslan said earlier about dedifferentiated versus not differentiated, but putting that aside, the dose response relationship becomes important. The other part we understand is that with the vast majority of chordomas, we have to treat infiltrative aspects of the tumor, including aspects where there is what we call an iatrogenic element to chordomas, where surgeons as talented as Dr. McKean and Dr. Gokaslan resect the tumor, but that resection bed can have pieces of tumor cells left behind that can grow into their own tumors. And so that becomes important to radiate as well. So, so two goals that we have: treat broadly and treat to as high a dose as possible. And so to do that safely requires some really innovative technology. For the past few decades, we've used radiosurgery, which allows us to escalate radiation dose, but doesn't allow us to necessarily treat as broadly. And then, we've come to appreciate that sometimes we see these marginal relapses when we're not able to treat so broadly. So with protons, we can kind of achieve both, and that's the goal of what we're trying to accomplish. And our technology with proton therapy continues to get better. I think in one of the prior educational sessions here at Northwestern with Chordoma Foundation, spoke about a technology we've developed called pencil beam scanning using apertures, and this idea of having a sharp edge to the beam and just trying to escalate dose as high as possible for, in this case, skull-based chordomas, Clival chordomas, when we're talking about, high-priced real estate around, like the brainstem and optics and temporal lobes, et cetera. So I think the literature, I think the clinical experience is showing that we're getting better with our approach to radiotherapy in terms of controlling this for a longer period of time and doing it more safely. There was a manuscript that came out that was a meta-analysis a couple of years ago, I believe in World Neurosurgery, that tried to combine all the data, summated it, and showed that there was probably the highest survival benefit with particle therapy to include carbon ion, but also protons. So I think it provided some proof of principle to the idea that we can get some long-term benefit with dose escalation.
Great, thank you. A question, this is really a general question for the group. Maybe I'll start with Dr. Gokaslan. Many patients are fortunate in the sense that their first point of contact with the medical and surgical care system when they are diagnosed is very positive, and they're in the right place at the right time for their diagnosis. But that's not always the case, and it's difficult for patients to know. The question in the question and answer box essentially is, in general, would you advocate for a second opinion, even if you're confident in the team that you're initially in the room with? So maybe Dr. Gokaslan, if you could, a talented neurosurgeon like yourself, if somebody comes to you and asks you whether or not a second opinion is warranted, what's your general approach to that question?
I always encourage a second opinion, even if the patients didn't ask for it. I would ask them to get other opinions as well. And I think there are multiple reasons why that could be quite valuable. Number one, in many situations, the types of surgical procedures that we propose to the patient may have significant morbidity or associated residual impact on the lives of these people for many years to come. And hence, that decision, that initial decision for a surgical resection of the chordoma needs to be made very thoughtfully, balancing the risks and the benefits of the operation in a very thoughtful manner. And I think that the patients need to feel very comfortable that they really have made the right decision before they choose that path. And I think that getting a second opinion, which in many cases tends to be quite supportive of the original recommendation, could be quite assuring to the patient that they are really making the right decision. So I think that in order to prepare the patient psychologically before they embark upon a very significant procedure with potential risks involved, that they are making the right decision, I think that is invaluable. In other situations where if they are being treated, regardless of how skillful the surgeon is, if the surgical team is not really used to treating a lot of chordomas, it may definitely be helpful to seek other opinions because differing recommendations can be made. And in many instances, not just a surgeon, but make sure that they get opinions from various radiation oncologists and the medical oncologists, and so that a comprehensive plan is really put together for the patient, because it's a lifelong disease. initial intervention has very significant risks and complications associated with it. So I think it's important that a team of physicians are involved in the care of the patient, and the patient will be followed for many years to come.
Just a comment really quickly, and I'll let others in the panel address this. You know, I can speak to this very well in the sense that I've walked both sides of the fence. And what you hear from patients frequently is there's a real power differential. So if you are, you know, Joe Blow Chordoma patient, so to speak, and you're sitting across the table from a talented ear, nose, and throat surgeon like Dr. McKean, or someone like yourself, or you're talking with your radiation oncologist, how does a patient feel empowered in the first place to say, you know, I thank you so much, and I respect, with all respect, I'd like to have a second opinion. What's a good strategy for the average patient to broach that topic? Because, you know, that advice is gold, absolutely, with a rare diagnosis and the implications for lifelong disease. Key to get multiple opinions, but patients often don't feel empowered to do so.
Yeah, I would just add, and I'll let Dr. McKean to follow up on that. I'm sure she has a lot of experience with that. First of all, I think the Chordoma Foundation is an incredible resource, and I think, you know, many of my patients that I treat surgically, they've already reached out to the Chordoma Foundation. Some of them are recommended by the Chordoma Foundation to come in. You know, they have given a number of centers where this type of surgery is commonly preferred, and depending upon their geographic location, they may have chosen me as a potential surgeon for their care. So the Chordoma Foundation is an incredible resource to guide the patient in the right direction. And secondly, I would urge the physicians to encourage the patients to speak up, encourage them to ask questions. And I really truly believe that my job as a physician is to educate the patient as best as I can about their condition, and then make sure that, you know, we are making the decisions together. It's not my decision. I'm not going to be, you know, dealing with the consequences of the surgery for many years to come. It's the patient's life and patient's decision and the family's decision. So they need to be fully involved in the decision-making process. It's a very complicated disease, lifelong disease, and it's a long journey. And I think that that needs to be done joint. I cannot really take the responsibility of, you know, prescribing a specific treatment to the patient unless the patient and the entire family is on board with the treatment.
I echo everything said. I think if your doctor tells you a second opinion isn't advised, I would definitely go get a second opinion, just because I think, you know, trust is so important in the relationship. Just like, you know, I want you to trust me. I want to trust that we have a good relationship, and trust is built on, you know, transparency and reflection and being honest about what we can and can't achieve. So yeah, I mean, I think if somebody tells you not to, be wary. The one thing I am mindful of is sometimes patients, it can be very expensive to travel or to find another opinion. So I think another thing that I try to offer is me reaching out also on behalf of the patients to ask my friends across the country, how would you manage this? And Dr. Gondi has taken like emails from me, and then, you know, like, hey, can I run this by you? Can I send you a snapshot of what's happening here? What do you think? Because sometimes second opinions can be expensive, so we can work together to communicate on the back end too.
I would add a couple thoughts, and always a pleasure to interact with Dr. McKean. Number one, with chordomas, thankfully, relative to other cancer/tumors, there's time. Unless you have a dedifferentiated chordoma, you have time to sort things out. There's no rush necessarily. So there is time to get a second opinion. And I fully endorse Dr. McKean. I tell my patients who ask about a second opinion, not only am I okay with it, I encourage it, and let me help you. Because you can call so-and-so center and get on the list and get in to see them. Or I can pick up the phone and call the person I know who manages chordomas there, and I can ask them to get you in. My approach is I don't tell them any about my bias. I just say, can you get them in? You came up with your own independent thoughts on this, and let's talk, and let's do what's best for the patient.
Awesome. Related to that, and Dr. McKean touched on this a little bit with regard to the expense and the logistical difficulties, often with regard to traveling to get opinions and so on. You know, fortunately, these days technology has enabled patients in a given opportunity in ways that we never had available to us before. But there's a question specifically with regard to international chordoma patients who might reside, for example, in a country or a place where access to best treatments is not available. For American centers in particular, I guess here, how do you handle requests that come from abroad to your centers?
I personally happen to know some of the surgeons around the world that treat chordomas. We have a large international consortium we work with the AO Foundation. There are a lot of surgeons involved in treating spinal chordomas around the world, and we do joint studies, prospective registry. So if the patient reached out to me and they are in a part of the world where I know there are a number of surgeons who could manage their condition, I typically share the name. And as a matter of fact, I respond to the email, CC them on that email, and have the patient make the contact with those individuals if they choose to do so. And I'm sure that is true for my radiation oncology colleagues and medical oncologists, and Dr. McKean is an ENT surgeon on the call here. I'm sure she's aware of some of the experts around the world, and they would be delighted to share the names of these individuals with international patients.
And just to add to that, to echo the comments that were made earlier with regard to the Chordoma Foundation, the Chordoma Foundation patient navigation setup is so well developed now that often the first point of contact should be there, and certainly it can help patients in the community internationally with that process if need be. I just want to touch quickly back to Dr. Gondi. You mentioned dedifferentiated chordoma. You know, in layman's terms, the question came up in the chat box. What does that actually mean? What's a dedifferentiated chordoma versus a good old garden variety chordoma?
You know, Dr. Gokaslan mentioned it earlier when he very appropriately stated that for dedifferentiated chordomas, first of all, you know, to consider closer MR surveillance, and he's right. We may not understand the biologic behavior simply off the pathology. It's always good to follow it with close MR surveillance the first year to understand its radiologic behavior. But there's a small minority of chordomas that have a behavior that tends to be faster growing. There's a higher what we call proliferation rate of a chordoma. In general, chordomas, the percent of tumor cells in a chordoma specimen that are actively dividing is typically on the order of single digits. But a dedifferentiated chordoma has developed a biologic behavior that is much more rapidly growing. And so sitting on something like that, especially if it's close to some high-priced real estate, can lead to more issues, more problems. And I've had, unfortunately, some patients where we had to act very quickly. And so in those scenarios, to the point about the second opinion, sometimes there's no time to do that. And most oncologists and surgeons will be very upfront and honest. The challenge with dedifferentiated chordomas is, you know, I think there was a paper that came out recently, one of the neurosurgical ones that I just read the other day, that generally they tend to have less durable control, especially after radiotherapy. And in those cases, I sometimes really emphasize the importance of getting as much surgery as possible. And it's simply, if we see it with every type of tumor biologically that has a rapid growth rate, that radiotherapy is very effective. But it's one of those, like, it's a little bit of a harbinger, like it'll shrink really quickly, but that's not necessarily a good thing because it can't hold it in place for that much longer. And eventually over time, I find those patients tend to grow back sooner than other patients. So just a very unique biologic trajectory relative to other chordomas.
Related to that, there was a question in the mix regarding long-term effects of radiation. So on the flip side, this patient amazingly is 38 years out from their diagnosis, 38 years, but in the last few years has developed some other issues, including growth of a tumor called a meningioma, tumor from the lining of the brain. And the question relates to what are the long-term effects of radiation down the road? What's the risk of other tumors? Is it the gift that keeps on giving in that sense?
Yeah, first of all, I think that's great that they are almost 4 decades out from their initial treatment. That's a win. But yes, with radiotherapy, there are side effects that we need to be very cognizant of. One happens to be the development of new cancers from radiation. Generally, in the skull base and brain, they are typically meningiomas, which some of them are benign. although some I've treated have not acted benign. It's one of those scenarios where the risk we generally estimate to be less than 2 to 4%, but it's also a function of how long a patient's going to live. So the longer we control their tumor, the longer they live, the higher the risk of developing a second tumor from radiation. Generally speaking, when I manage chordomas, complex chordomas, I kind of in my mind put a priority list together. So what are the high price real estate, the brainstem, all the spinal cord, the vision nerves, the temporal lobes, the tumor. And I put it in a sequence and I say, what do I prioritize? And I do something that I like to call playing the percentages. So when Dr. McKean or Dr. Gokaslan touch the spinal cord, for instance, they know there's a risk of causing injury to that. They know that if they do that, it's a neuronal injury from surgery. In radiation, we can touch the spinal cord and not cause injury. It becomes a proportional risk. The higher the dose, the higher the risk of causing injury, what we call playing the percentages. And so I try to play the percentages in my mind as we develop these complex plans. And to be honest with you, the risk of developing a second tumor decades down the road is kind of lowest on my priority list. And it is an unfortunate outcome that can happen with patients who we've radiated.
Great, thank you.
Can I add something I'm pretty passionate about because I see it missed sometimes down the road now. So in that prioritization scheme, the pituitary gland for skull-based chordoma is also low priority because we have medications that can replace the hormones that main master hormone gland makes. But I have seen patients, 10, 15 years down the road with fatigue, and I look at the beautiful quality of life information from Chordoma Foundation and see high rate of fatigue and, quality of life issues related to that. And then I send to hey, who's checked your pituitary function? And then I send in and find out, oh my gosh, they're severely hypocortisolemic. So I think, another thing to just watch for when we're talking about side effects that are necessary and good for prioritizing taking care of the tumor is making sure the pituitary is functioning well, thyroid function, all those things that could happen down the road.
That's a really good point. If I can add to that, I like to plug all my patients into an endocrinologist from the get-go, and I tell them you follow with them for life. Every year, get your labs checked.
Yeah, maybe one quick comment I can add here as it relates to tumors that may be touching the spinal cord or critical other neural structures. Sometimes we design a limited surgical procedure to get the tumor away from those critical structures, if possible. Even if you're not going to be able to remove most of the tumor or the rest of the tumor, then by doing so, we can reduce the risk of radiation injury to the spinal cord or the surrounding structure. Sometimes this surgery can be a great way of preparing the patient for radiation and minimizing the risk of the treatment.
Now, let me add to that. It's a really good point. So when there is gross tumor next to with the spinal cord or brainstem, to durably control that, we need to escalate the dose, that dose response relationship. But when Dr. Gokaslan and Dr. McKean are able to take that away, then we don't need to treat that area to nearly as high a dose. Maybe we treat the surface of the brainstem a little bit if it's touching it. But that significantly and dramatically reduces the risk of injury from radiotherapy.
Well, some great comments. Perhaps we'll segue from there a little bit into some of the medical therapies to control chordoma. So a question for Dr. Gounder. Let's start perhaps with imatinib or Gleevec, which historically many patients were started on to try to control long-term recurrence of chordoma. What's the status of imatinib in the mix, and are there other so-called targeted therapies that are better? This is a long question, I guess, and related to that, lots of buzz around something called brachyury, and so perhaps we can discuss that for a few minutes.
Yeah, no, I think this is a very long and complicated discussion, but let me try to, break it down in the interest of time. So I think the first thing is to determine whether one has the conventional chordoma or the dedifferentiated chordoma. I think that's the first branch point. The reason being is that the dedifferentiated or poorly differentiated chordomas have a completely different biology. They have a completely different molecular programming, and treating them may is very different than how you treat the conventional or the vast majority of chordoma. So I think that's the first branch point in understanding where you are. Let me first start with the rarer scenario, which is the dedifferentiated or the poorly differential chordoma. So these tumors very often or most often will have a mutation in a gene known as SMARCB1 or INI1. So the pathologists need to check for it. This is something that the next generation sequencing and other molecular testing can detect, but not always. Sometimes it just requires a simple test known as an IHC, where this gene should be missing in patients with dedifferential chordomas. If that gene is missing, there are clinical trials with drugs under a class of agents known as EZH2 inhibitors or immunotherapy. These things are, there's been some anecdotal reports on the utility of these drugs. Dedifferentiated chordomas, unlike the regular chordomas, also are sensitive to chemotherapy. The standard chemotherapies that we do not use for the vast majority of chordoma patients, these things can be very sensitive to chemotherapy as well as to radiation. So these tumors are fast growing, they metastasize very quickly, but they can also respond to chemotherapy. So that's one part. Thankfully, this is a very small and rare type of chordomas. For the vast majority of chordomas, these things do not respond to most of the chemotherapies in our toolbox across all kinds of cancers. We've tried this for the last 3 or 4 decades and really nothing really works. 10 years ago, I think for the first time, drugs like Gleevec sort of came around. There was a very large study, but the response rate and benefit from that study was quite low. It was less than 5% of people had some tumor shrinkage. We never quite figured out why Gleevec worked in a small subset of patients. There was really no further kind of research to dive deeper into the utility of Gleevec. So we never really even quite found out why it worked. So there was no opportunity to kind of supercharge that understanding or that knowledge. So Gleevec is not something that I routinely use. I think it's variable. There are some people who reach for it as the very first drug. I don't, in my personal opinion, I don't reach for it. It's not been approved in chordomas really in the US or in Europe. Many groups, both in Europe, in Japan, in US, have tried many different drugs in chordomas. For example, sorafenib, you could think of it as a little bit of a Gleevec, but with little extra, it's like Gleevec 2.0. So there was a study done out of France that showed that sorafenib could be active. But again, there's been no single study that has slam dunk said, this drug really helps X% of patients with chordoma. So what is next? So what we found is that even though these conventional chordomas under the microscope looks the same, when you do genetic testing, there are enough differences from patients to patients. So this notion that there's going to be one drug that's going to sort of solve everybody's chordoma problem is not yet available. In the future, maybe if you have a drug that goes after brachyury and it does a really nice job, maybe that's all is necessary. Maybe one drug will conquer all chordomas. But right now what we're finding is there are lots of drugs, many in clinical trials, many supported by the Chordoma Foundation. And I'll just rattle off a couple of names. So palbociclib or Ibrance is a drug that is approved in breast cancer. There is some very nice data that was published out of Germany. So there's a study ongoing in Germany looking at palbociclib or this breast cancer drug in Europe, but that study is not going on in the United States. There are some drugs that look after EGFR. So drugs like afatinib, cetuximab, these things are currently in clinical trials, some in Europe, some here in the United States, one in Pittsburgh, I believe, some at MD Anderson and a couple of other places these studies are going on. A lot of work being done by the Chordoma Foundation in terms of doing preclinical modeling and testing. What that means is that the Chordoma Foundation over the last 10 years has successfully developed a lot of Chordoma cell lines. These are basically tumor cells that grow in a petri dish. And they've been able to test a variety of different compounds and have noted some nice activity. So a lot of those things are now being evaluated in clinical trial. I think the data is not going to mature for any of these trials for the next 3 to 4 years. The most sort of useful data that may be coming out in the next year or two may be about this palbociclib or Ibrance from Germany. But outside of that, lots of new studies coming along, including immunotherapy in combination with radiation out of Sloan Kettering as well as Hopkins. But I think next 3 or 4 years, we will know. But even with all these drugs, my suspicion is that it's not going to work for everyone. A subset of chordoma patients are going to benefit, but it's not going to solve everybody's problem.
Thank you, Dr. Gounder. That was a big topic to take on. I think we've realized over the years that it used to be, I think, a few decades ago that we thought of cancer as a diagnosis as if it was a single disease. We all recognize that it's a family of diseases, and within that family, even the rare diagnoses like chordoma are a family of diseases unto themselves. And so your points are well made and well taken. I'm going to circle back to initial treatment approach and approach for some recurrences as well with regard to stereotactic radiosurgery and gamma knife approaches, because that has come up with past panels around this. And again, today, a number of questions around gamma knife surgery and stereotactic radiosurgery as opposed to physically removing a tumor with a knife. Perhaps Dr. McKean, I can start with you.
Oh gosh, that's another no easy answer. Every tumor is different, and we need to sit down with our heads together, all of the surgeons, the radiation docs, and the medical oncologists too, to say what's the best step here when it comes to recurrence. I'm not sure I have anything genius to say other than communication is critical, and really assessing how much do we think we can get surgically and what's the risk of that. Likewise with stereotactic radiosurgery or re-irradiation, what's the risk of that in reality? And if we're going to need both, then it's just a matter of timing of what's going to be best for the patient and how will their reconstruction heal and how will that impact timing. But Dr. Gondi, what do you think about that?
Yeah, no, it's a really effective tool, radiosurgery, and there's so many different approaches to it. We have gamma knife as well. I'm actually in the gamma knife area of our center, but it has to be used judiciously, to the way Dr. McKean mentioned. So my general bias is upfront. Initial management of a resected chordoma, I typically don't use radiosurgery. Some of my colleagues elsewhere have different biases, and that's perfectly appropriate. The reason I don't is just for the risk of marginal relapse. But at the time of recurrence, yes, I have. I've treated a very broad area, and it happens there's a treatment-resistant clone of tumor that is growing through, in part maybe because it's close to a critical structure that I wasn't able to appropriately dose escalate as much as I wanted to. And a couple of things that come to mind. Number one, the safety of it and the risk, to Dr. McKean's point, has to be really thoroughly discussed. But two, I always think about the patient and their longevity. I generally believe that for a gross tumor that is growing, radiation, no matter how high a dose you deliver, is never going to be as durably controlling of that as surgery. Surgery can take out proliferative tumor, therefore control that area much more effectively than any radiation modality. Now, in some cases, we just can't. And that's where we have that discussion in the tumor ward with our neurosurgeons, skull-based surgeons, spine surgeons. You know, what do we think? Is this a reasonable option? If someone's 75 years old, is that the smartest move? Probably not. But if someone's 35 years old, yes, maybe we take on that surgical risk because of that concern. And then, yes, if that's not an option, then I do consider focally gamma knife radiosurgery to that area to try to provide as good durable control. And we've had some good successes, knock on wood, thus far in terms of being able to, you know, we found the treatment-resistant clone, we treated it further, and now we're back into disease control.
Is it possible to use stereotactic radiation, radiosurgery? Is it possible to use that in the aftermath of a full complement of proton-photon therapy?
Oh, I see. That's a really good question. So you mean as a boost thereafter?
Yes.
So
sorry to interrupt, but so if you've had surgery, say it's been 5 years, and you've had the full great initial resection, you've gone to what great center to get your radiation, you've had good control, and then 5 or 6 or 7 years out, you have a recurrence.
Yeah, no, absolutely. No, radiosurgery, is very much on the table after the full dose of radiation was given with protons. Again, it tends to be a focal area that is growing. It may or may not be next to an area of critical structure. If it's say next to the left optic nerve, as an example, like coming out of the cavernous sinus, and it cannot be resected, then it's a discussion. I'm a big believer, as everybody is, on open and upfront discussions with patients. There's a risk playing the percentages that when I treat this with radiosurgery, in a couple months to years, the patient may develop monocular blindness in that one eye. But if I don't, the tumor will cause it. So let's try to control this tumor, accept that risk, and try to keep things under control, as an example.
If I may here, as it relates to stereotactic radiosurgery or proton beam radiation, potentially as an upfront treatment, as opposed to a surgical intervention, that can rarely be a good option for patients who are elderly. They don't really have a lot of life expectancy, or there are so many other comorbidities that they cannot really have a potentially high-risk surgical procedure. I have had a number of patients, for example, that they were diagnosed with another malignancy at the same time, lung cancer or breast cancer, and they were imaged for that reason, and they were found to have a lesion in the spine or in the skull base that proved to be a chordoma. In those situations, we sometimes do not necessarily subject the patient to a major surgical procedure because the patient needs to deal with a secondary the other malignancy that would require multimodality treatment, which is more fatal in many ways. And so in those rare circumstances, upfront radiation as more of a definitive tool can be a reasonable option.
And I think we always have to keep observation on the table when things are complicated. I think we'll all nod our heads, because the last thing we want to do is hurt somebody. If, first do no harm, it's not always the right answer, but sometimes it is. So it should be a part of our discussion.
Great point. Dr. Gokaslan, a couple of questions regarding the risk of surgery on sacral chordoma with regard to the morbidity or the side effects that come after the surgery, particularly with respect to bladder and bowel function. So first of all, how common are those? And secondly, what are broad strategies for sacral chordoma patients to help deal with? What do you tell patients with regard to what they can expect with regard to managing and living with those complications?
It's an excellent question. The risks of bowel and bladder control, loss of bowel and bladder control following the surgical procedure, that really is highly dependent upon the location of the chordoma within the sacrum and the surgery that's needed to remove the tumor completely, and what nerves are going to be sacrificed to be able to achieve that objective. In general, if the chordoma is located in the sacrococcygeal area at the distal part of the sacrum, S5, coccyx in that area, typically the risks of surgery as it relates to loss of bowel and bladder function tend to be minimal, because in many of those cases, critical nerves can be spared and the patient typically would have a normal bowel and bladder function. Having said that, by the mechanics of that area is altered a bit as a result of the surgical intervention. A rectal sphincter muscles can be affected, or the support of the rectum posteriorly may be compromised, and those things can create some bowel issues, but not necessarily loss of bowel and bladder control. As the tumors climb up higher in the sacrum, typically the resection will require progressively more and more risk of loss of function and cutting more nerves. Typically, the tumors that involve the S4 and S5 segment that can be excised by preserving both S3 and S2 nerve roots bilaterally, those patients typically have a very good bowel and bladder function. Anytime you start sacrificing the S3 nerve roots, you start running into more and more loss of bowel and bladder function. If you were to cut all the sacral roots below the S1 level, then typically you would have complete loss of bowel and bladder control. And those situations can be handled in a couple of different ways. Loss of bladder control, even if you were to cut all the sacral roots, typically inability to empty the bladder. So that patient typically can manage with the self-catheterization to empty the bladder. And the loss of rectal control tends to be more socially compromising for the patient. And you can potentially do a colostomy procedure in those cases like we do with rectal cancer. And the bowel then output can be managed more effectively. And lastly, if you were to cut only one side of the sacrum and you sacrifice all the sacral roots on one side and preserve everything else on the opposite side, the patients tend to have a very good bowel and bladder function. So it's a long, convoluted answer to the question, but it really all has to do with how many nerves need to be cut to achieve a complete resection of the tumor, what's going to be left behind, and whether or not what's left behind is going to be sufficient enough to control the bowel and bladder function effectively. And if you lose all of it, there are a number of different strategies one can use to deal with that.
What sort of healthcare professionals do you use as the ancillary providers in your team to help patients deal with those sorts of issues?
Yeah, we typically work with colorectal surgeon to help us with those cases for both to mobilize the rectum away from the sacrum to minimize the risk of injury to rectum during the surgical procedure and the risk of injury to sphincter muscles for that matter. And we typically work with a plastic surgeon to make sure that the incision is covered with vascularized tissue and is likely to heal. One of the more common problems that we deal in sacral chordoma patients after the surgery, many of those patients sometimes temporarily would have difficulty controlling their bowel and bladder, and hence the wound tends to get contaminated with fecal material, which tends to create problems with postoperative infection. In those cases, sometimes we even do a temporary colostomy, which would then be reanastomosed, but in those, just to protect the incision so that we can have it heal and then restore the intestinal conduit after that the patient heals, and sometimes after the radiation treatment.
Thank you for that. I have a couple of questions regarding pulmonary or lung nodules. Dr. Gounder, how often do you see those in the course of treating your chordoma patients? Are they common? Do they represent metastases? What's the general approach to managing those?
Yeah, it's a good question. You know, I think there's a little bit of a referral bias in what I see. So as you know, in general, many patients who have metastatic disease or for whom surgery or radiation has initially, not worked or subsequently recurred, they end up seeing me as a medical oncologist. So, when medical oncologists get involved, I think we scan more extensively to look for lung metastasis or for metastasis in other locations, including skin metastasis. So I think I probably see a little bit more. I hate to put a number over here, but if I would say maybe 10 to 15%, we would see some lung metastasis. But what I've noticed is that these lung metastases in chordomas generally, but not always, are sort of slow growing. And just because you see a lung metastasis doesn't mean yes, it should be biopsied to confirm that it is indeed chordomas and not some other cancer or some other benign process. So that's rule number one. The second part is just because, when somebody has tumor in the lungs or elsewhere, it is stage 4 chordoma. It has spread to stage 4. But as soon as someone hears the word stage 4, it sets a lot of fear in that setting. But stage 4 chordoma can also have sort of an indolent course. We have seen like tumors in the lung that maybe grow a millimeter or 2 every 6 months or once in 2 years, and you can safely watch all of them. So when I do see somebody who's got metastatic tumor, the instinct is not immediately to start a treatment, but really to get a sense of, can this also be watched carefully? And in order to get that information, one has to have a sense of like, how fast is this growing? So if the chordoma is very slowly growing, say in 6 months or a year, one does not need to immediately react to it or put patient on a trial or some kind of a drug. If it's more fast growing, then refer them to radiation, thoracic surgeons, or ablation, or any number of things, including drug therapy. So it's really not, a stage 4 chordoma does not sort of have the same implication as with other cancers. You really have to get a sense of what is the speed at which things are moving.
Thank you. In my own case, this question about lung nodules first came up, I think 7 or 8 years ago. I think it was the first Ask the Experts panel that we did. And I had just recently been diagnosed with lung nodules myself, about which we've done exactly nothing in all these years. And they're just as present now as they were then. And they've had no implication for the quality of my life or my therapy whatsoever, just to your point. Is there any ability for the chordoma then to spread to other places? I had one question with regard to chordoma in the femur, for example. How often do you see places outside of the lungs?
Yeah, you could actually see it all, in a lot of different places. I mean, I think we've seen even in unusual locations like lymph nodes, which we sometimes, we don't see it, but any location is reasonable. Lung is, of course, the most common places. I would say the second most common place is skin. You can get these subcutaneous skin nodules, and it's interesting, and I don't think we've really understood it, but the biology of the tumors that happen to go to the skin are probably a little different than those that go to the lung, and they behave a little differently. But just because someone has a tumor in the lung doesn't necessarily mean it goes to the skin. There appears to be, and this is really my own opinion, not based on data, that there may be sort of subsets. There are some tumors that are programmed to go to the skin, some that are programmed to go to other locations like femur or lung, but rarely does it spread in every single anatomical location.
Sure, thank you. One of the strategies that is used in other tumors, for example, in this question that was put forward regarding prostate cancer, is embolization of a tumor. So I'm not sure to whom I should direct this question, so self-select. The question is it possible to embolize or choke off the blood supply to a chordoma tumor, just like you would perhaps choke off the blood supply to a prostate cancer, thereby choking out nutrients that they need to survive? Is that done in chordoma? Is it possible? And if so, why or why not?
Typically, it's not really an effective strategy in managing chordomas, just for one of the reasons being that the chordomas tends to be relatively avascular tumors, and hence there are a lot of blood vessels that feed the tumor. Some of the tumors are great for embolization, and kidney cancer metastasis, for example, we use it commonly to kill the blood vessels to take the tumor out safely, to remove the metastatic lesion, for example. And some of the primary bone tumors, giant cell tumors, a good example, adenomatous bone cysts, and so forth. There are some tumors that we use repeated embolization as a therapeutic strategy. But unfortunately, chordomas are quite avascular. They don't have a lot of blood vessels, and I don't use it, and I'm not aware that anybody uses it to control the chordomas.
Yeah, and I have one more thing to Dr. Gokaslan's perspective is, generally those tumors, cancers that do well with embolization have a dominant feeder that goes to it, that you can shut that out. I would even say prostate cancer does not have that. There's no dominant feeder. It's part of it's embedded in the circulation of the organ or bone structure in the case of a chordoma or a prostate gland, in the case of a prostate cancer. So that becomes challenging to then embolize because you don't have one avenue to go to.
I could add something. Yeah, I agree that embolization is not something that we've done, but ablation specifically of certain lung nodules or certain other places where maybe surgery is not optimal or has worked out nicely. And the difference between embolization and ablation is embolization is choking off the tumor's blood vessels. Ablation is just kind of really freezing it or for lack of a better word, frying it in a very small place. But a lot of this really depends on the size of the tumor. If it is very large, these, whether it's embolizations or ablations, become more and more difficult. So for example, if you have several lung nodules, most of them are stable, but one happens to be growing at a much faster rate and continuously with every scan, that small lesion may be a good candidate for ablation. And we've done that frequently and saved the patient unnecessary surgeries. Whether we, in the long run, ultimately change the trajectory of the chordoma or not, no one's ever studied or answered that question in a systematic way. But we do a lot of things sort of in not necessarily with the highest amount of evidence of data.
We still have a number of patients who are told by their care provider in their center when they first come to the point of diagnosis that there's some confusion about whether or not this represents cancer or not. You know, the big C word, and the question here with using the term BNCT or benign notochordal cell tumor, notochordal arrests and that sort of thing. So just definitively, is this a cancer? Is it not a cancer?
It is a cancer. There's the benign equivalent of E. chordosis physolifera, which does not grow, does not invade, and doesn't spread. But by definition, anything that invades surrounding tissue and metastasizes or spreads elsewhere is cancer.
Yeah. I'm sorry.
No, go ahead.
No, this question comes up quite often, and the patients come in and they are told that they have chordoma, that's a benign tumor. It cannot be far from the truth. It is a form of cancer, and I describe not only to the patients but to our trainees this is a locally invasive malignant tumor with low propensity for distant metastases until later stages in the disease. And so it's a malignant tumor, it's a locally invasive tumor. Early on, it remains to be a local problem. Later, it can metastasize. So any tumor that can metastasize by definition, one of the definitions, a malignant tumor, and hence it is a malignant tumor.
Yeah, thank you for stating that clearly. I feel like each time we have one of these sessions that needs to be said and clearly, but not to be said in such a way that it sends people skittering away in fright, right? So because, you know, the whole approach of all of the excellent work that you are doing, that you all are doing, and the Chordoma Foundation is helping to navigate, is to try to turn this as much as possible into a chronic disease. There are many cancers that people manage to live with quite well. But this business of patients being told that this is benign, don't worry, this is not going to shorten your life, unfortunately, it crops up far too often in these discussions.
I just want to make a comment here. I think that's also relevant, is that the metastasis from a chordoma is not the same as metastasis having from a lung cancer or a stomach cancer and other organs. In many of those cases, when the patient is put into the stage 4 category where they have distant metastases, their prognosis tends to be much worse, and they don't, in many cases, may not live necessarily for many years. Whereas chordoma patients, even they have metastatic disease, those patients may live for many years to come. And so it's not, metastasis from a chordoma is not the end of the world like it would be metastasis from a pancreatic cancer, for example.
Yeah, I was going to say the same thing as Dr. Gokaslan. I am very selective when I use the word cancer, in part because I see so many different types of cancer. The only thing about this that in my mind makes it a cancer is that it can spread, but it is an aggressive infiltrative tumor, no question about it. But it is important to distinguish, because cancer, immediately people think, oh, what about that friend of mine who had breast cancer that metastasized. I remember how her life ended, and this and lung cancer. It's not the same thing. You can live with this tumor that has the potential to spread.
Yeah. Well, I have you, Dr. Yeah, go ahead. Sorry.
All right. No, the only reason I was going to say, but I do think it's important because I think information is empowerment to just understand the long-term nature of follow-up and just that, so that we're honest about, we need chest imaging periodically and things like that. Likely all's going to be well. It is totally different than other cancer experience, but I think knowledge is power. So.
I was going to ask Dr. Gondi a question that was put forward regarding radiation. Is there a role for parking some radiation into the tumor before having surgical resection, followed by radiation again? What's the approach to that?
I think I saw that question. I think that meant a preoperative radiotherapy strategy, yeah. Which is used for some spinal, mobile spine and sacral chordomas. I personally have had an evolution in my approach to this. This has been largely driven by some collaborators and friends at MGH. Tom Delaney is a great radiation oncologist out there. He's used this strategy and it makes a lot of sense. The strategy is to treat the tumor before surgery to deposit DNA damage in those tumor cells. And then at the time of surgery, tumor is resected. And if there happens to be any spillage of tumor cells during the course of surgery, or even if there happens to be some infiltrative aspect to the tumor that's left behind, those tumor cells' DNA is already damaged, and therefore they're cytostatic. They're not growing, and so that might have an impact. And then you follow that up with the area where you think there's the highest likelihood to have microscopic disease with the boost. What I've learned from collaboration with our super talented spine surgeons out here at Northwestern, including Jean-Paul Walensky, is that there is a risk of some wound complications, and I'm sure Dr. McKean and Dr. Gokaslan can speak to that. And it's one where when I've asked about it, I certainly say, okay, it's an option, but my preference is if Dr. So-and-so, in this case, I work closely with Dr. Walensky, if Dr. Walensky can take this out and en bloc, then I don't want to impair his ability to do so, because that's a really important surgery. And I would prefer to do that. And then perhaps afterwards, I don't need to see it. You can just watch this and, just follow Dr. Walensky. So that becomes a multidisciplinary discussion. I don't want radiotherapy to impact the capacity of surgery to be done safely and effectively. And Dr. Gokaslan brought up the sacral chordomas, and I like the interesting idea about diverting on the colostomy to prevent the wound infections. When I see someone post-operatively that may have like a positive margin, and then I do consider treating, I don't want to touch them until several months after surgery. I want everything to heal. The worst thing that could happen is to radiate something that's not fully healed, and then we're in a bigger disaster. So I've changed my approach. I tend not to do preoperative approaches, but it's a multidisciplinary discussion. But I do understand why Tom has considered that and has some experience doing that.
Well, my approach to this is really selective. So there are some cases that I would consider giving preoperative radiation, or giving a portion of the radiation pre-op and the remainder post-operatively. And typically those cases are cases where there's a high risk of getting into the tumor during the resection, or the topography of the tumor is such that we cannot really remove in one piece. So we have to really cut the tumor into two pieces. We call this planned transgression of the tumor. Since we cannot cut the spinal cord out, we typically cut the ring of spinal vertebra into two pieces and remove in its entirety. In those situations, we know that we will enter the tumor, and hence we typically administer preoperative radiation for exactly the reason that Dr. Gondi indicated, that we can deposit DNA damage. And if there is any spillage of the tumor, which we are very careful during the surgery that doesn't happen, but if there is any chance of that happening, then the implanted tumors would be damaged already, and their capacity to grow would be much less. And with the additional radiation therapy, we will be able to better control it. But if it's in an area where we feel relatively confident that we're going to be able to remove the tumor in one piece, and having a wound complication would really complicate the treatment of that patient, particularly additional radiation. And in that situation, I try to avoid this because it does definitely increase the wound complications significantly, despite the fact that sometimes my colleagues from MGH indicate that it's not as bad as you think it is.
What about the skull base, Dr. McKean? Any utility?
Yeah, the skull base, I think uniquely too, we are at a gravitational disadvantage for wound healing. We're generally in front of a big, huge pool of CSF, cerebrospinal fluid, and the pressure on that fluid is coming out towards us, and we're trying to get it to heal right where people are breathing and swallowing and things are moving, and then to have it radiated where the wound healing is poor, it just puts us in a big disadvantage and a much higher risk for cerebrospinal fluid leak with meningitis and very difficult complications. So I haven't used it. I wouldn't say, I don't know that much about it. So I wouldn't put a foot down and like, it's never possible, but I just haven't used it myself.
For sure.
Although I've operated in the post-radiation setting for recurrence, and we make it happen. We find vascularized reconstruction that can help.
Related to that, in the skull base post-radiation, how much difficulty does that create for you with regard to other areas of the body with regard to scarring created by radiation and so on?
The scar is not as difficult more than just getting things to heal afterwards. And so it's just making sure we find tissue that has really good blood supply that we either take from a different part of the body and essentially transplant to cover the location, or if we have tissue from, under the scalp or inside the nose that we can rotate to cover, we can make that work as long as it has good blood supply. But it's much harder after radiation than before.
Just one comment.
Go ahead.
I'm sorry. One comment related to the radiation and the scarring, and I think that it has to do with timing of radiation. So if you were to operate on the patient relatively soon after the radiation treatment, anatomical planes are typically well preserved and you can do the surgery well. But if you allow many months to pass after the administration of the radiation and you go back and operate on that patient, then it really can turn into a nightmare scenario from a surgical perspective, because we cannot really develop the surgical planes that we can easily do that under the de novo circumstances. And that's why it's so critical to determine whether or not you're going to administer the radiation treatment and when you're going to administer it, and whether or not the surgical resection is going to be a part of the treatment plan, and timing of that. And all of that is extremely critical to optimize the results of the treatment, and hence really needs to be discussed in a multidisciplinary forum. And you say, okay, this is what we are going to do, A, B, C, and then A will come first, B will be within 2 months after that, and C will come, if that were to happen, et cetera. And I think coming up with that definitive plan from the very beginning becomes very critical.
So a couple additions, if you guys don't mind. Sorry, Dr. McKean. So I was just about to say what Dr. Gokaslan said. So I just want to break it up into 2 scenarios, what's happening radiobiologically as it relates to wound complications. One is the scar. The scar is a function of fibrosis that develops post-radiation. It happens months to years down the road. It's just the biology of that. The other is the scar that develops in vasculature. The scar that develops in vasculature can happen in a more accelerated fashion. So you can still see wound healing issues, even if you take them to surgery right afterwards, because the vasculature is not really fully providing a sufficient blood flow to that area. So there are 2 phenomena that happen from post-radiation. Now, one other thing I want to mention, Dr. Gokaslan mentioned, in defense of Tom and the awesome team at MGH, my general sense is part of the reason why we've considered preoperative radiotherapy, especially for mobile spine, maybe even sacrum tumors, is that treating postoperatively, especially with protons and particles, in an instrumented spine is incredibly complicated. It raises, in fact, there's literature from Tom, that Dr. Delaney, that talks about relapses that happen after that. And it always happens right around where the instrumentation is. And I have a case right now that I'm struggling with that. What I like to do when I see a patient preoperatively, and I say, well, maybe we don't need to do this preoperatively, but let me work with the spine surgeon on instrumentation. these are the beam angles I'm going to use, the approach I'm going to use to treat this. And instead of putting metal rod right in the middle of where I want to come, maybe we try a carbon fiber rod if they have the habitus to be able to permit that we can treat through and provides enough tensile strength just temporarily for a few months, and then we can swap it out on the back end when we're done. As an alternative, I found that to be a little bit more useful to maybe prevent some of the stuff that we learned from treating instrumented patients.
Thank you, Dr. Gondi. Dr. McKean, did you have as a comment?
I should make a caveat. Treating in the skull base is different than the soft tissues of the sacrum when it comes to scarring. It's like when I get in the neck, the scarring in the soft tissue is different than in the skull base. So yes, thank you for clarifying, both of you all, that, and Dr. Gokaslan, that it's different for the sacrum.
Thank you, Dr. McKean, and thank you to all of our esteemed panel members. I'm cognizant of the fact that we are at time. Like drinking like a fire hose whenever we convene like this and talk about all these issues. And the negative side to it, I suppose, is that we can't possibly get to all of the complexities, into all of the questions, into all of the issues. So I would encourage those in the audience with additional questions and so on to reach out to the Chordoma Foundation, to the Patient Navigation Service. It's fantastic, as most of you know already. And join me in a round of, I guess, virtual applause for our 4 panelists who gave up their time today to join us with their expertise. A huge thank you to all 4 of you. And I hope that we can lean on you again in the future for in a similar sort of session as we move forward and we learn more about this disease. And so thank you all for your efforts in helping us turn this into a chronic disease for now, and hopefully one day into a cure. Thank you enormously from the bottom of all of our hearts for all that you do. Absolutely. And thank you to you as well, Ed, for moderating. The Chordoma medical community is one that's always so generous with their time and gracious care of their patients. And on behalf of the patient community and all of us at the foundation, we really appreciate you all very much. Thank you for all that you do. And as Ed mentioned, to all our participants, thank you so much for joining us, and please check our website for upcoming webinars in the virtual conference series. There's 2 more this year. I put some information up on the screen there where you can find that, and if you submitted a question that we didn't get to, or there's anything else we can do to assist you, please contact us. You can email support@chordoma.org or go to chordoma.org/request-help, and we will be there for you. So everyone take care. Thank you so much. Be well, and we'll see you for the next webinar in September.
Thank you.
Bye.
Thank you.